So, what are some questions you're frequently asked in regards to incapacitated patients?
Um, when will they get better? When will they walk again? Uh, when will they wake up?
No.
Um, what can I tell his job? When's he going to go back to work? Just pretty much they ask when's he going to be normal, which many times is not an option.
Yeah.
And it's not that I'm making it not an option, it's that his body has decided it's not an option for the disease process that it's going through. And so it's really, mostly what I get is questions that indicate a non-understanding of the situation.
Yeah, and so when patients ask us these kinds of questions, the only real truthful answers we can give them, other than reinforcing what a physician says, right,
Right.
is our assessment findings.
Right.
And this usually occurs day to day, so they'll call or come in and say, "How is he doing today?" Right?
Right.
It's a pretty classical
Yeah.
introduction of any patient family member to us for an incapacitated person, somebody that cannot consent for themselves. And so we present assessment findings generally. That's what I do. Is that what you do?
Yeah.
Okay. And some of those assessment findings, all of those assessment findings that they're usually interested in involve neurology.
Yes.
Right? So we have a standardized set of neurological assessments that we do on a very frequent basis for these kinds of people. And it usually involves something like a Glasgow Coma Scale, right?
Yes.
And that involves?
It involves your ability to have your eyes open, your motor strength, and my mind is blank.
I believe it starts with how the eyes open.
Yep, eyes open.
Motor function and obeying commands.
Obeying
so
commands,
localizing the noxious stimuli or posturing. That's the second aspect. Third aspect of it is, I think, vocal articulation, right?
Yes.
So with an intubated patient, I only remember that because almost all of our patients in the ICU usually intubated, so it's none. So you get a 0 for that aspect of the score. So what we're looking at is your ability to open your eyes, your ability to move your body, or specifically move your body in response to stimuli or requests. And thirdly, your ability to say words and how you say those words. That's very, very inconsequential in terms of what is a quality of life for a person. So if we can't really tell you based on an assessment that simple how your family member's really doing.
No, that just shows us in the moment what their capability is.
Yeah, and that can change with just even things like sleep.
Yes.
Which is interesting.
Sleep or pain medication.
Yeah, it can change almost instantaneously. So that's a poor assessment variable, but we still use it nonetheless. Other parts of our neuro assessment include like neurovascular checks, right?
Yes.
And those include?
Well, I don't know. What do you want to call a neurovascular check?
Just think about, in Cerner when you're charting under neurological. Just actually choose whatever part of the neuro check you want to go over.
Well, okay, so neurovascular check, we have mentation, we have being alert and oriented. I literally do not want to know what you want to call a neurovascular check. Literally.
Yeah, unfortunately, it's really strange in Cerner the way they classify it. So Cerner's our charting system, where they call neurovascular checks like peripheral pulses and sensation. So peripheral sensation limits.
Yeah, I mean, if you want to call like CMS things neurovascular check, I suppose. So, we can test for like numbness and tingling in your extremities. Like he said, peripheral pulses, although I don't think that it necessarily has much to do with anything other than
Agreed.
Your cardiac health or your vascular health. But
Agreed.
I think that the biggest part of a neurovascular check is whether or not you can feel your extremities, which a lot of people can't.
Yeah, when incapacitated, absolutely.
A lot of people with diabetes can't.
That too, peripheral neuropathy. Yeah. So, so things we do when that's limited is we check for reflexes, right?
Yeah.
So we'll stroke like the bottom of the foot and see if that inspires a reflex. Or we'll see, I like to squeeze hands and see if they'll squeeze me back. That can also be reflexive, though. It's not always something
Well, it's
that
definitely a
is,
reflex.
yeah,
When you're squeezing hands with somebody, you definitely have to do it a few times to figure out whether or not it's a reflexive movement or if they're intentionally doing it.
yeah. And I've had a lot of family members interpreting that reflex as an actual higher thought capacity or response
Absolutely.
to stimuli. So that's why it's sad to say, but the gold standard, I guess, that we use is show me two fingers, right?
Mm-hmm.
So if you can show me two fingers when I say show you two fingers, what we're really looking at there is we're looking for an auditory capacity. So we want to see that the sound is coming into your ear, your brain is interpreting that sound, and then your brain is sending the electrical impulse to your hand to show two fingers.
Yes.
So that's a pretty good standard. So repeating that statement over and over again, as I've seen some family members do, sometimes for upwards of like 10 minutes, and then seeing a spontaneous twitch in a hand, that's interpreted as the person having mentation is not what we would call a correct assessment on their behalf when we're educating them.
No, that's called apophenia, looking for something so you find it.
Sure.
Make your brain saying, this happened, but it really happened because you were waiting for it to happen.
Yeah. That's an interesting term. I've never heard it before.
Apophenia.
Apophenia.
Phenia.
Phenia. All right, I've got it now. Apophenia. So all of this to say, in our neurological checks, they are not conducive like people would think they're conducive to functionality or predictive measures of functionality.
Yeah, so actually, when we look at the effectiveness of TPA, the clot busting drug that we give people, they don't actually start measuring outcomes until after 90 days. Sure. So anything that happens in the hospital or immediately thereafter never actually gets studied at all for the effectiveness rates of it. It takes 3 months for us to do that, which ironically, the other part of that is when they did studies of neurological recoveries of patients in hospitals, while they don't measure it in one study, when they do it in the others and they do measure it, they found that any neurological improvement that you're going to have is predictive from the first 72 hours, actually.
Yeah.
And if you haven't recovered some amount of some function, say your ability to move your left arm in the first 72 hours, you probably will never recover that.
Yeah. And that totally makes sense from the pathophysiological perspective that we introduced with brain tissue ischemia and
Yes.
brain and neurological cellular death. That tissue dies, and once it's dead, it does not come back.
Correct.
And this is easily a predictive factor for us, and we can see it. We can see those kinds of things on scans. We can see the place in the brain where the tissue has necrosed based on swelling generally.
What you see months later is, or a year later, if you look at somebody who's had an ischemic stroke, you then follow them and do another CT scan. About a year later, there's literally a hole filled with our cerebral spinal fluid. So normally there'd be brain tissue here, but instead you see a hole that's filled with fluid, and that fluid isn't, of course, brain tissue and can't have any function. It's just a space filler.
Yeah, and whatever functionality that tissue has incapacitated, it's gone.
Yes.
It's not coming back.
Every part of your brain is specifically mapped to control, or every part of the brain cortex, which is the outside of the brain, where everything happens for us, is specifically mapped to have specific control over specific function.
Yeah, and that's where I think a lot of people have misconceptions too, where really super smart physicians that have like neurological specialties can look at a scan and they can predict difficulties the person's going to have based on the scan, and that is not always 100% correct, and they'll usually give you levels of they'll give you levels of prognoses. So generally I'll hear like our neurointensivist saying they're going to have trouble swallowing. I'm worried about them losing their gag reflex when he looks at a scan, and that's perfectly applicable. But what people need to realize is that when their physicians are saying something like that to them, they need to take it with a lot of severity, because especially when a physician says something like, they will never have the ability to swallow again. They will never have the ability to walk again. They will never be able to speak to you again. When there's assuredness in like a neurologist's approach to a patient or patient's family members with those statements, most of the time the line of questioning I'll get after that neurologist leaves is, well, do they have brain activity?
Yeah.
And a lot of times, yeah, absolutely. Electricity still flows through your brain. You can have electricity flowing through your brain with no ability to communicate with the outside world or interpret information coming into your sensory perception whatsoever. It's just electricity flowing over cellular mediums. And the kinds of tests we do to determine that, like an electroencephalogram, an EEG, will show electrical activity in the brain.
Absolutely.
And those smart neurologists can look at those scans and they can see actually from the way the electricity flows parts of tissue ischemia and those kinds of things. But what nobody can see when interpreting that data is whether your loved one or the patient is going to get out of bed or talk to you again.
Right.
Yeah, they make those predictions based on interpretation of like scans, like the amount of tissue that has died in the brain.
Yeah, sometimes it is a situation where they can give a realistic prediction that no, or not even a prediction, they can assure you that it'll never happen. But many times, Mark's very correct, there's a significant amount of damage, it's in this area, your ability to understand speech is in the same area. Maybe it was completely obliterated. Maybe it wasn't. They may be able to recover some of it. And that really is just time will tell.
Yeah. Yeah, so that's the spectrum of prognoses, which is very fair. And a lot of people don't realize that when you come into the acute care setting with these types of injuries, our job is to stabilize you initially. And after we finish stabilizing you, then we use the prognostic factors to help you make your own decisions. So like guide you in doing what you think the patient would want.
Absolutely. We want to inform you so you're empowered to make a decision versus making one off of conjecture.
Yeah, absolutely.
Everybody knows somebody who disagrees with the doctor.
Yeah. Yeah.
As soon as you come into the hospital, everyone has an opinion. Mm-hmm. Very few of them have an educated opinion.
Yeah, that's absolutely true too. So one of the reasons why these advanced medical directives can be overridden so easily, I think, plays a part in these severe traumatic events. Like say a car crash.
Yeah. So
let's say for example I have an advanced directive where I say I don't want CPR or ventilation. Because of the things I've seen in my career, well, my wife will override that immediately. As soon as I'm in a car crash in the hospital, one, they won't have access to that advanced directive immediately, so I'm going to get the emergency medical services right off the bat, and then whatever care they'll give me initially until a social worker can even evaluate me or look up for those documents. But two, my wife's going to come in and say, no, we're going to wait 2 weeks. And we're gonna put him on a ventilator. We're gonna keep him, intubated, and I want to know definitively, what chances of survivability are and functionality are. And the only really disturbing problems we see are when we have a high level of assuredness in a prognosis, and family members directly go against the wishes of our patients.
Yeah. Interesting. To note, I actually had a patient who had an advanced directive, and the family understood it very well. So the patient was brain dead, and organ donation is frequently pursued at that point.
Oh, yeah.
So the patient's advanced directive actually said, I do not want to be an organ donor in it. And the family said to the organ donation people who are obligated to talk to them by law, if it were up to me, I would say, yes, let them donate. But this piece of paper that they signed says no. So the organ donation entity actually almost went to court to try and override this person's advance directive. Wow. Because they said, well, the family wants to donate, and the only reason that they're not is because the person said no. But think about that. That's actually horrible. You know, organ donation is a wonderful thing, but that's actually a pretty terrible thing. Yeah. Because we're saying, you specifically said no, but we're just, you know, you have good options, so we're going to override that. Yeah. It's the same concept, really, of trying to railroad past somebody's wishes to get what somebody else wants, when really it's not about what somebody else wants. It should be about what you want.
Yeah, absolutely. And the reason why we have all of these, you know, all of these interim steps in you making your own healthcare decisions with an advanced directive is because there's more at play than what's logical. What is logical, or what is best defined for society, might be that everybody's a default organ donor and doesn't have a say in it. Absolutely, we'll get more livers and hearts. But we have to take into account, even in healthcare, that there's a holistic aspect to things we do. And some of that holism includes religious and personal beliefs.
Absolutely.
I wouldn't even say some of it. I'd say that's probably one of the biggest aspects of it. That's why, as a Jehovah's Witness, you can go to the hospital and you won't worry about us forcing somebody else's blood into you because it goes against your religious beliefs. If that's what you want, we will not do it, and we'll do everything in our power otherwise. That's your right. That's an absolute right every patient should have. Just like, you know, this patient's absolute right was to not donate organs. He did not want that. And whether it was religious or not, that has to be respected. So when we talk about respecting, you know, advocating for your patient or respecting somebody's wishes when they're when they're incapacitated, these are the kinds of issues we can run into. And this is why there's so much paramount importance to it, because think about what you would feel like if you were in that person's body at that time, experiencing the things they're experiencing, and knowing full well that you told them you didn't want any of this, and then carrying out these kinds of interventions for years, essentially years.
That's a bad situation to be
in. Yeah. It makes us quite sad, especially when it's, you know, full well admitted that this goes against what the person expressed they wanted in the first place, or you're overriding a document that they put together for this exact purpose.